Welcome to this Explainer. Okay, let's dive right into this truly fascinating initiative led by the University of Queensland and Mater Hospital. Their mission is absolutely crucial. They want to completely co-design and enhance the cancer journey for women. We're talking about everything from that terrifying initial moment of diagnosis well into long-term recovery.
To build a fundamentally better model of care, you need a solid foundation of raw, on-the-ground insights. So the platform Mindhive actually helps you gather these insights directly from 6 cancer care clinicians across Queensland. They did this by asking them 11 pivotal questions to figure out what's working for patients right now and, more importantly, what desperately needs to change.
Here's a quick look at our roadmap for today. We're going to take all that raw clinician survey data and translate it into a compelling, logical patient journey across these 6 key areas, from establishing a new model of care all the way through to building an interdisciplinary workforce.
Section 1. A new model of care.
This project was designed alongside Mater Hospital, which is a Catholic not-for-profit ministry with an extensive health network. They partnered up with a really ambitious goal in mind: to co-design a model that actually supports the entire spectrum of the cancer experience. That means covering everything from active treatment right through to long-term life after cancer. When looking at the outcomes from the very first question about top clinical priorities, a really clear picture of holistic care emerged. The clinicians stressed the absolute importance of continuous exercise throughout all phases of treatment, having patients who are fully informed, and ensuring every single woman feels genuinely heard and emotionally validated.
Section 2. Patient and family concerns. Let's move to and see how this builds into the specific fears weighing on everyone involved. Synthesizing the answers from questions 2 and 3, we uncover a really profound dual burden. Patient concerns are highly immediate and physical, right? They're focused on the risk of recurrence, surviving the initial surgery, and coping with harsh side effects. Meanwhile, family members carry a slightly different weight. They absolutely share that sheer terror of survival, but they're also intensely worried about keeping the family unit together and managing everyday life responsibilities amidst all the chaos.
Section 3. Gaps in holistic support.
Shifting our focus to question 4, we have to look critically at what's currently failing. While physical symptom monitoring and physiotherapy are generally handled quite well, clinicians pointed out some critical gaps in holistic care. Chief among them is a distinct lack of psychological support to help patients cope with emotional turmoil. There are also severe service deficits in regional areas and a really worrying drop-off in continuity between treating teams the moment active treatment ceases. It's almost like stepping off a cliff when you leave the hospital.
Section 4. Defining recovery and survivorship.
And this brilliantly illustrates a crucial conceptual distinction between 2 terms we often hear used interchangeably. Based on question 5, clinicians defined recovery as the immediate active phase of regaining physical, emotional, and mental function right after treatment. Survivorship, on the other hand, is that much longer period down the road when active treatment is totally over and no medical personnel are seen.
Which brings us to a really compelling question. What exactly defines a successful recovery? Is it just the medical charting, or is it something more?
Well, question 6 revealed a major tension in how care is delivered today. The current system is hyper-focused merely on the absence of cancer, getting clear margins and finishing specialist appointments. But a truly successful recovery should be about the presence of holistic healing indicators. The system is great at checking if the disease is gone, but it frequently fails to check if the whole person is actually healed.
Looking at questions 7 and 8, this gets even more complex for women with metastatic disease. The ideal support strategy involves highly individualized psychology plans, exercise, and psychoeducational groups. However, and we have to be objective about this, clinicians pointed out a massive hurdle. There are severe funding limitations that prevent robust public psychology services or long-term group support. The clinical desire to provide this care is absolutely there, but the financial structure acts as a brick wall.
Section 5. The role of peer connection.
When it comes to questions 9 and 10, peer connection aims to bring people together to share those incredibly heavy experiences. But integrating this into formal clinical pathways actually has mixed success. Why? Well, structured support groups simply aren't effective for everyone's unique personality. Add in the physical hurdles of travel and location, and it becomes pretty clear that you can't just prescribe peer support as a one-size-fits-all solution.
Section 6. Building an interdisciplinary workforce.
Now, what's really interesting about this slide is the immense scale of the team required. Question 11 makes it clear that to actually make this holistic model a reality, the workforce goes way beyond just doctors and nurses. It requires allied health professionals, language services, and crucially, emotional and spiritual care, psychologists, social workers, pastoral care, and dedicated Aboriginal and Torres Strait Islander support. It literally takes a diverse, interconnected village to heal a patient completely.
To gauge how the clinicians actually felt about this whole co-design process, a sentiment analysis was conducted on their feedback using Mindhive's data visualization, and the engagement was remarkably constructive. The frontline workers are clearly eager to voice their insights and help shape a better system.
In fact, the comments yielded an average positivity rating of 71%. In the world of systemic healthcare reform, which can often be so fraught with burnout and frustration, that is a massive number. It shows a genuine, widespread enthusiasm for this initiative among the very people who know the system best. So the crucial point is what happens next. UQ and Mater aren't just sitting on this data. Step 1 is finalizing this comprehensive care model. Step 2 is using this framework to apply for an NHMRC partnership grant to secure vital funding. And finally, Step 3 is presenting this blueprint in journal publications and conferences. They are taking this case study and turning it into actionable, real-world outcomes.
Which leaves us with a vital question to ponder. As we shift our focus from merely treating the disease to actually supporting the whole person, how will this holistic, co-designed model ultimately reshape the future of women's cancer care globally? The groundwork being laid here offers a really promising glimpse into a much more empathetic future. Thank you so much for joining me for this explainer. Keep questioning, keep learning, and definitely keep an eye on this vital research.